who's joining us from Cameroon, and we'll be talking about circumcision from a male perspective first, and then from a female perspective afterwards. Letabo, are you able to speak?
Hi, Prof. Yes, I am able to
All
speak.
right, I'll let you take over so you can just, I was just opening up because you were struggling, so you can take over with the introduction. Sure.
All right. Good afternoon, everyone. Sorry, I had just some minor glitches with Microsoft, but I think this should be sorted for now. So I'd like to welcome everyone to today's Global Surgery Academic Meeting. I am Dr. Letabo Hlongwane. I am a Global Surgery Fellow and a MSc student, and I will be facilitating today's meeting. So today we have two incredible speakers. Firstly, we have Dr. Salukezana, a senior urologist and lecturer at the University of Cape Town. And his topic today will be on male circumcision in a South African context. And secondly, we have Dr. Fanny Desekdolon. She has an MD, Master's in Public Health, and also a PhD. She is a public health physician. She's a researcher and also a program manager. She's also an assistant lecturer at the University of Banda in Cameroon, and she's also the Design African Executive Director at the University of Bua in Cameroon. And she will be talking about female circumcision in an African context. So today's topic is quite dear to my heart. This year, as a surgical community service worker, I am currently at a rural hospital and I work in the surgical department in Mpumalanga. I was given the privilege of leading a circumcision clinic program with an NGO called Right to Care. And we were performing daily circumcisions on 10 to 16-year-old males so during the period of June and July, they usually go to an initiation school where they perform traditional circumcision at these schools. But unfortunately, some of the kids would have a significant number of the boys would come back with from these circumcision schools with septic wounds, and we would have to treat and manage them. I remember a case that I won't forget. A child, he was 12. He presented in DKA and septic shock, secondary to the septic wound. And I think that's when I started really being very passionate about advocating for young boys, especially in this neighborhood and in this town, to kind of come to the clinic and get circumcised, and then they can go to the initiation school, and there was no necessary need for them to get further circumcision. It was important also for me to kind of respect the culture that they grew up from, because for me it was more important for me to just inform them. It was quite sad to know that some of these boys would have to grow up with disfigured genitalia, which would have a huge impact on their self-esteem and confidence as a man. So it was very important for me. But with that being said, I would like to hand over to Dr. Salukezana, who will shed some light on this very important topic on male circumcision in a South African context. Dr. Salukezana, hi.
Hi, Letabo. Can you guys hear me and see me?
Yeah, I think we can see you. Yeah, we can see you.
Okay. Are you happy with how the slides are showing? Do you want me to try and make them bigger?
No, it's working well.
It's fine. Okay. All right. Yeah, no, thank you so much for the invitation into the global.
Hello.
What the other, daughter's name again, who also works in global surgery, which is quite nice and enriching that we have to go and actually address problems at the community. So when I was given this topic, it was, it seemed like not a very easy topic to talk about, and because it's a bit of a sensitive one, and as you all know how traditional circumcision has been, and the fact that we hold it to ourselves as men, and to in views to try and uphold the culture and everything. And but I mean, I think I agree with Letabo that there's been significant problems that we're encountering with male traditional circumcisions, and it was very humbling to realize that when I was going through this topic, it was actually not nice to realize that there isn't much research done on it. The only research we have is actually quite long ago. I think up to like 2018, there isn't much research done on it. I mean, obviously because of the issues between political, traditional, and social issues around it. So just getting into the topic, I'm just going to move my slide. Okay. All right. So just a definition on circumcision, just for the audience, because I did ask what audience we'll be having. So that I can be able to try and make things a bit easy and understandable. So definition of circumcision, it is the surgical removal of the foreskin in males, which cover the tip of the penis, which essentially means the glans. And obviously we'll be discussing more about traditional rather than medical circumcision. Just as a way of an introduction, many theories have been proposed regarding the origin of circumcisions, which include religious sacrifice, rite of passage, and aid to hygiene, and ways to differentiate between cultures. As you know, some cultures do not do circumcision, some do, and there's different ways how they do it. Male initiation is mainly practiced amongst certain groups within the Xhosa ethnic group, which live predominantly in the Eastern Cape, and most of the data that we have is actually from the Eastern Cape because of the problems that we're getting there. And traditional male initiation has become the focus of government and media attention as a result of unacceptable large numbers of initiates being severely injured or dying as a result of practices related to initiation. The issues really relate to regulations relating to the skills of the traditional surgeon, selections of the surgeon, traditional nurses, so-called ikangata, or financial gains that are perceived by the so-called unqualified surgeons in the communities. Just a brief indications of circumcision. This basically is for medical. It's really mainly for penile pathology, as you all know, phimosis, paraphimosis. And there's also been some research looking at prevention of STIs, HIV transmission, penile cancer. We know there's good data on that. If one gets a circumcision as an infant, that would significantly reduce the risk of circumcision. Obviously, if you do get circumcised when you're an adolescent, the risk is not really reduced. And obviously for aesthetics and the sexual function, for some patients would actually report difficulties and discomfort when they actually have problems with their foreskin. And then these are just a bit of medical complications that we know of. I'm just highlighting this so one can actually realize that medical circumcision, it doesn't really have significant complications as opposed to what we'll hear later. Bleeding and infection are the most common ones. Surgical, as one can cause urethral injuries, glands injuries, removal of excess skin as opposed to just the foreskin, and inadequate skin removal, can get scarring, can get aesthetic complications, cosmetics. And in none of these, we're seeing, worst case complications, including death, which is what we've been seeing recently in our population. When I was given this topic, because of the fact that we're focusing on traditional circumcision, I thought it's quite important. I remember a lecture that I had in anthropology, where one of our lecturers talked about the rites of passage, and we were talking about focusing in this case, talking about initiation rites. And if I remember very well in that class, male students literally walked out as the lecturer was busy discussing the details of initiation. I think it's quite important that we need to understand that it's a birthright, and we still need to respect the cultural implications and how it's done, obviously not compromising patient care or patients in general. So I'm just going to talk about the cultural and social significance of ritual circumcision in the Xhosa society. As I said, most of my references are mainly from the Xhosa ethnic group, mainly in the Eastern Cape. So it basically marks, it's a mark of identity. That's one of the social significance. And it's also a gateway to manhood. One moves from being called a boy to become a man. And it's also acquisition of rights. Rights basically meaning, to simple things like you can sit with men and share whatever drinks they're having, or other rights include previously, one would have rights in engaging in sort of in marital affairs. You can get married. They talk about sexual activities that previously women would say they would not have anything to do with the men, as well as hanging foreskin. And also, one of the most important things is conferral of responsibilities, that you're a man now, so you need to act accordingly, which comes with a lot of responsibility, taking care of your home, taking care of your parents, your siblings, and access to privileges. And also, another big thing is the social status, and that's why I have this picture on the left side. Because as soon as you get back there and you're wearing this nice suit, everyone is aware that you've been to an initiation school. Then you get this big social status that you're a man, and people generally respect you and the community as such. So what are the key role players in a traditional circumcision or in this ritual? So the key role players in this ritual are the traditional healer, who gets to be nominated by the community in that area, which get involved in so-called search to prevent evil spirits from sort of getting into the space and preventing issues with the initiates. And also the traditional healers also also acts by strengthening the traditional surgeon from preventing them from any other evil spirits that may actually affect the whole initiation process. The traditional nurse, or the lodge guardian, which is called Ikangata, who basically gets involved in taking care of the initiates, and often there's multiple of them. And the other big role that they have is getting involved in looking at wounds and changing dressings. And obviously the initiate is also very important in the whole process. So there are 3 phases of the ritual Xhosa male circumcision. So the preparation period, which basically may date months way before the actual time when a boy has to go to the initiation school, which includes also key role players in identifying uSosuthu. Basically, it's a Xhosa word meaning basically the person that in that year or in that region has decided to take his boy to the initiation school, and then everyone else would sort of tag along. And obviously that person has to be respected and known in the community and all their values. And Ikangata, as I mentioned earlier, is a person that's also nominated, who's going to be a traditional nurse, who's going to take care of the boys at the initiation school. Inglebi being the traditional surgeon, who's going to be performing, who's also nominated by the including the traditional leaders also the traditional healers also involved in deciding who the traditional surgeon will be. And the actual operation, which is the circumcision, which is performed by the traditional surgeon. So I think that's where the critical thing is when you talk about the operation. So the issues around that is ensuring that, again, it's done by someone who's experienced, who's nominated, who's known in the region, and the practices should be well controlled and monitored in the sense that they should not be using the same instrument. And there's also how they then control bleeding, because sutures are not to be used, because if one uses sutures and then there's issues when the initiates are actually going back to the community, and there's actually sometimes, depending on the region where you are, people will actually go around showing off their penises and proving that you actually had it done in the bush than having it done in the hospital. Other big critical issue that's a problem is hygiene. That is very important. That's usually an issue. And the stuff that's used to sort of wrap around the area that's been circumcised. They often use sort of tourniquets that actually cause too much compression to try and stop the bleeding because there's no suturing, which then can cause problems in blood supply. And again, if there's not good hygiene, there can be infections, and that's where the problems start. And obviously, the other one then is seclusion, privation, and break from privation, which basically means this encompasses the first 7 days of the initiation school, where the initiates are basically not allowed to drink water, not allowed to have meat, usually, or salt, because the notion is that they should not be going to pass urine because they'll get pain, and not taking salt is thought to prevent them from getting erections, and then they get pain from all that and disrupting the wound. Just moving forward. So what are the main complications then related to traditional circumcision? I think the biggest highlights are the fact that there's lack of skill and knowledge on part of the traditional surgeons, leading to incorrect surgery. And this is commonly seen in areas that are not well regulated, where government officials are not too much in control or involved in the processes. Alcoholism and drug abuse, where you'd find that people that are actually taking care of the kids at the initiation schools, the amakangata, where they'll be drunk and not and then there'll be abuse even on the initiates, and then reuse of instruments without sterilization, sepsis and gangrene, which is seen because of hygiene issues. Dehydration, one of the biggest things, as I mentioned, in the first 7 days, that there will not be drinking of water would not be allowed. Also, the biggest thing I mentioned earlier, the rise of fly-by-night circumcision, circumcisers, which is motivated by financial gains, which has actually been postulated to be one of the biggest things that's been seen that's causing the rise of these issues. Absence of parental involvement is one of the biggest things as well, because people sometimes often tend to pay people to go and sit and watch their children, and which often becomes a problem because they will not be as invested as you would be as a parent. So I found this paper again. It's an old paper, 2007, and I quite liked how they looked at traditional male circumcision in the Eastern Cape, and they looked at the causes, the complications that one gets or causes of death based on the season. So they looked at the causes of death during the winter season, and they also looked at the cause of death during the summer season. And if you look at the numbers there in the study, that in the winter season, most of the patients, the cause of death was related to sepsis, gangrene, and pneumonias. Obviously, it's a bit colder in winter, and dehydration. which was another thing that I also noted very importantly, hypothermia was also noted as one of the problems. And if you look in the December seasons, the circumcision-related complications, obviously mentioning sepsis, talking about gangrene, auto-amputations were seen commonly in December. And issues with lightning, because often quite rainy and there's a lot of storm in the Eastern Cape around that time. Assault by traditional nurses, clashes with community members. I think, obviously, on the circumcision-related complications, well, I think a dehydration should probably be included in December, because often quite warm and, the initiates are not allowed to drink in that season. So I saw this, I was trying to look at stats as to how many people usually get into problems and deaths that we see with circumcisions in South Africa. Again, I couldn't really find a recent article that looks at the numbers. I found this in the in a paper called Africa, which was a highlight that was published on the 24th of December 2021, that 34 South African youth died during the initiation rites, which is quite a concerning thing. And again, I saw this. This was in July this year in the winter season, in the South African news, that there were 8 deaths that were recorded in the Eastern Cape around that time. Again, these stats are not accurate, as I mentioned, because the problem is that I've actually realized that there isn't much done in terms of research looking at this issue, even though it's actually something that we should be concentrating on, and actually sparked, an interest in me, maybe through global surgery, getting involved in such things, because we just don't know much about it, and that's a big problem. And obviously, it's got to do with issues related to politics, traditional issues, and obviously social issues, that these things are not talked about, especially in the Xhosa ethnic groups. So, I mean, the complications that we get, as mentioned, one of the most and the worst complications that we get faced with, and we often here in Cape Town see patients coming through with auto-amputation of the penis as a result of gangrene, which is often as a result of, as mentioned earlier, tourniquets that are put around the penis to try and stop bleeding, and which is also associated with infections and wet gangrene and then auto-amputation. And we see a few of these cases quite commonly in the December season. And these patients come this side because obviously they have heard that there has been the first world successful penile transplant at Tygerberg. And this was a paper published in 2015, where it was a multidisciplinary team at Tygerberg that has performed the first ever successful in the attempted penile transplants in the world, which was giving hope to victims of botched ritual circumcisions. And obviously, they talked about penile cancer, even in men with severe erectile dysfunctions. I mean, obviously, these are all ethical issues. I mean, talking about, transplants in other instances. And so currently there's just still one. And so these patients usually come this side because they're hoping that they'll get a transplant. And obviously, because of the fact that it's got significant psychological issues and the fact that they've heard about the good successes from this case. So I also came across a paper actually published just after that in 2018. And that's the reason why currently I would assume there's not been any more transplants being done recently in Tygerberg, because this paper's penile transplantation is an appropriate response to botched traditional circumcision in South Africa, an argument against. This was a paper published by Moodley et al. in 2018, and in this paper, I'm quoting this from the actual paper. In this paper, we argue that given the limited healthcare resources in South Africa and competing healthcare needs, prevention is more appropriate response to botched circumcision than penile transplantation. botched circumcisions are a social problem and not just a medical problem. And for reasons of effectiveness and ethics, need to be treated as such. So basically, it seems that there's significant resources that are actually spent in one doing a transplant, which, as we know, we probably should be concentrating on dealing with this social problem, and not just the medical issue and just offering a transplant with the resources that we currently don't have. And just to end off my talk, I think we do know very well that the African society take a lot of pride in the circumcision season, in the actual process, and that's why you can see how these people are happy in seeing their kids getting back from the circumcision schools. But even with that, I think we still need to play a massive role. And I feel from what I've seen in looking at this topic, I think global stage probably would play a significant role in trying to dig deep into these issues that are related to it, other than just holding it up as a ritual or a traditional ceremony, even though we are experiencing significant problems in terms of the morbidity and mortality that we're experiencing with traditional circumcisions. And just to end of the topic, these are my references. And I must say, I really realized from this that there really isn't much work done on this. And we are still getting significant issues related to botched circumcisions. We're getting, mortality and morbidity from it. And I feel, I even asked my colleague in Mthatha, who's a urologist, and I said to him, have you ever done a topic in presenting about traditional circumcision in Eastern Cape? And he said, no. Are you involved in any research? Is there anything that you're doing about it? And he said, no. And it's only because of the complex interaction between the politics related to it, the traditional issues and so forth, that are actually preventing people from going forward. And in actual fact, I believe people that are involved in it, and I'm sure there's lots of professionals that have actually gone through the process, that could actually be involved in getting research done and seeing how we can work to improve this. Thank you.
Hi, thank you so much, Dr. Salikazana, for your talk. I think it was really amazing and really important. I too struggle to find a lot of research and data on it. And yeah, it was quite difficult. And I do agree that it's quite an important global surgery topic that needs to be followed up. I do agree with you. I think we can ask questions after our next speaker, if that's fine. And then after our next speaker, we can have a question session, if that's fine. All right. And I would like to introduce our next speaker, Dr. Disakdalon. Hi, Dr. Disakdalon. She will be giving us a talk on female circumcision. You can start your talk, Doctor.
You're muted.
Yes, good morning, everyone.
Good morning.
Try to share my screen. It looks like I need permission. Maybe can I just send you my presentation because I'm having difficulties with the Teams?
Can I share the one you sent to me in the morning, or have you changed it?
Oh, I did some minor changes.
Okay, all right, then you can send it to me, Letabo.
Yes.
Do you have my email address, Doctor?
Yes. I am really sorry. I thought it was a
Yes.
Zoom meeting, so I just realized that it was.
Maybe whilst we're sorting out the presentation, I just wanted to say to Dr. Sam, thank you so much for an amazing presentation. And I think it brings so much insight because we talk about this, but no one is really doing the research as you've highlighted. And, you know, I know one of the famous quotes is, without evidence, you've just got an opinion. And so there's a lot of opinions in this area. But also partly why it's taken such a long time for us to get to this place is also because we didn't know how to get involved, you know, because in our team, none of us are really experts in this area. So we'd really love to work with you and maybe just to see how do we start, maybe get an MSc, somebody doing a bit of research in this area, and maybe then slowly build some, evidence base in this area. Thanks.
Yeah, thanks God for that, Prof. Yeah, no, it's a very interesting thing. In actual fact, I'm not purely Xhosa. I am from Matata, that side, not Sutu. I'm Hlubi. People may not necessarily know what tribe that is. Quite close to the Sutus. So in my region, we don't get these things. To be honest, not much, and it's because I think they've adopted getting a lot of male nurses being trained to basically be involved in circumcision rituals and stuff who actually come from the same region. So that's why it's not a big issue if you're getting a guy who's gone through the same thing from the same region and getting involved in doing the circumcision. The problem is that people probably have in the Eastern Cape is that you're going to bring someone from KZN who's Zulu, who probably has never circumcised himself or circumcised in the hospital, and then now they come and get trained, and then now they're doing the circumcision in the Xhosa area in the Eastern Cape, and the guys will not like that. And getting a lot of the medical practitioners involved also works. In some areas on the other side, Tsolo, Manfletcher, and that area, there's a doctor who actually was involved in initiating this whole process, who has now trained a lot of people under his name. In fact, male nurses are actually doing the circumcision, and they're actually using different instruments per patient. I think they're using a Gomco sort of clamp, and they just follow them up, you know, a week later. But I mean, I agree with you. There's just no research in this. It's a very touchy subject. That's why we're struggling with with getting research and volunteers.
Dr. Fanny, can you see the presentation now? I'm not sure who's, I was trying to share later, but I think you're also sharing, so go ahead.
Yes, I can share. I can see my presentation. Yes. Okay. Okay. Thank you very much. So, good morning once again, everyone. I am Dr. Disak Delong, a public health physician, assistant lecturer in the University of Bamenda in Cameroon, and also I work in a research center based in the University of Buea with partnerships with University of Cape Town and University of California. Professor Massimo is actually one of our co-directors, and this is a honor to have this opportunity to talk also about female genital mutilation. Slide. Thank you. So the presentation, I hope, will not be very long. Just the objectives, background, and a brief situation in Cameroon and difficulties. Slide, please. Thank you. So the two main objectives that I wanted to highlight here is just to familiarize the audience. As Dr. Salukazana said, we have a very interesting audience here, just to familiarize everyone with female genital mutilation, since we are talking about male circumcision, just to also say something about female circumcision, mainly called female genital mutilation. and also raise awareness about the phenomenon in Cameroon. Slide, please. So definition, female genital mutilation is a partial or total removal of external female genitalia or other injury to female genital organs for non-medical reasons. So this part of non-medical reasons is very important. Slide, please. So classification, where WHO has updated, because usually we had 3 types of mutilation, but we have another 4th type, which is more appropriate with the definition. So the 3 first types depend on the removal of the female external genitalia. So you have type 1, where you just have the clitoris with remove, or we have that a small hood, clitoral hood, also called female prepuce, that is removed. We have type 2 with involvement of ablation of minora labia, and type 3 is infibulation. If you see in the picture, we have this partial or total narrowing of the vaginal opening through the creation of a covering seal. So, but besides these mutilations, we have all other harmful procedures that are done in female external genitalia for non-medical reasons, also fall into the definition of female genital mutilation. Slide, please. Sorry. Hello?
Hi. Sorry, I'm not sure what happened there. Can you still see the presentation now?
Yes, I can see the presentation. Okay.
Okay.
Thank you. Can we move to the next slide, please? So a small history about that. It's an ancestral practice.
Okay, there's a big one.
It's an ancestral practice. Hello?
Sorry, someone wasn't on mute. I think they're on mute now. Sorry, doctor, you can continue, please.
Thank you. So it's an ancestral practice. I found some similarities with the previous presentation. So it's an ancestral practice. We are not sure of the origin. So, and it is predominantly done in sub-Saharan Africa and Arab states. Sub-Saharan Africa, like the United Nations Fund from Population identified like 90 countries where female genital mutilation is practiced, and among those 90, we have 30 or 33 countries that are in sub-Saharan Africa, mainly in West Africa and Eastern Africa. But what I don't know if it's a surprise or not, but also we have South Africa is also included in the list of the 33 countries where we have some cases of female genital mutilation that have been observed, but I don't know if it's still present now. So it is usually done globally. It is usually done to girls between 9 and 15 years old, and it is most of the cases are practiced by traditional healers or traditional female elders, and many sociocultural reasons are evoked, like it's the same like the traditional male circumcision in South Africa, like it is girls' initiation to womanhood and so on. But the main reason is to control woman's sexuality. So traditionally, it helps to promote, it is supposed to help to promote virginity before marriage and also prevent female infidelity. And we also have, due to this strong belief, you have some modern medicine midwife who still perform this practice, which is unacceptable because it has no medical indication. So no matter if you are a modern midwife or traditional midwife, there's no medical indication of that. And it has several consequences. Slide, please. Thank you. Several consequences. I did not give all the consequences here, but we have short-term consequence, or I can say general consequences. You have pain, you have shock, you have hemorrhage, we have infection, because usually you see the picture here. This is a traditional blade. Dr. Salu Kazana was talking about that. This blade, I'm not sure this lady is going to change this blade between different girls. So we have infection, tetanus, other bacterial infection, viral infection, including hepatitis, and of course HIV. And at short term, we can have death from infection and hemorrhage if not managed on time or properly. Thank you. So other consequences, we have urogenital impairments like cysts, abscesses, scars, urinary incontinence, and with the infibulation, this is an image here with a kind of draw of infibulation. You can have menstrual disorders and menstrual retention and so on. Slide, please. We also have consequences on sexual and reproductive health. We have, for example, painful sexual intercourse. We have lack of pleasure in the intercourse also, hypersensitivity of the zone, complications during childbirth, both for the mother and the baby. Some studies have shown that ladies with infibulation has higher risk of facing childbirth during delivery. And we also have infertility and obstetric fistula. Slide, please. Of course, psychological consequence, trauma linked to the process, because I'm quite sure there's no anesthesia during the process. Anxiety, depression, frustration, inferiority complex. I did my studies, specialization study with a lady who was from West Africa, and she did not really discuss about it, but when we discussed together, it was like I had the impression that she felt that she was losing something, because she was not feeling, she was married with like 4 children, but she was not, she could not relate to what we call the sexual pleasure that a woman can have during sexual intercourse. So at times you can feel like you are not a woman like the others, this inferiority complex. We also have all those marital conflicts and divorce that is also cited among the psychological consequences. Slide, please. So, yes, please, can you move to the, yes, no, it's okay. The situation in Cameroon, no, next slide, please. Thank you. The situation is in Cameroon. Sorry. I showed a picture of Cameroon. Previous slide, please. Cameroon is a country in Central Africa. It's quite far from South Africa, you can see here. So approximately 27 million inhabitants, slightly more women than men. And in Cameroon, according to the last demographic health survey of 2004, they revealed that it was done, the age was, approximate age was 5 to 9 years old. And the most common type was the type 1 and type 2. They had very rare cases of infibulations. And according to the census, as I was saying before, you have traditional midwives and also some modern medicine midwives that perform female genital mutilation. Slide. So the situation in Cameroon, you will have like, the good news is that we have a significant drop in 20 years. Like the United Fund for Population has identified in Africa like 17 countries where they have a focus to fight against female medical genital mutilation, and Cameroon is not among, because they say the prevalence is less than 2%, but which was not the case by the mid-1990s, where the national prevalence was 40%. So this is thanks to law enforcement, education of girls, of women, that this is not acceptable, involvement of traditional or religious leaders, because I did not say it enough previously, but it has not been demonstrated to be a religious, neither Christian or Muslim practice. So we involve all those religious leaders to try to discourage people to do that. And also, Cameroon has previously a fund to financially incentivize the providers, like those traditional healers, because it was also a business. So some ladies had they had some support from the government to change their business. They had some funds, they had to change their business, do something else to earn to gain their life, and not do perform female genital mutilation anymore. And this is thanks to all those that we had this significant drop. Slide, please. But unfortunately, I'm sorry, when you transfer a slide, it always does that. So unfortunately, we can also say that female genital mutilation is still persistent and eventually resurgent in Cameroon. I was really okay with the previous speaker, because as you can see, there is no official data since 2004. So, but we have independent surveys, and also in my literature review, I also had the same thing. Like you have GRI literature, as they are commonly called. You have reports or journals and reviews and so on. So, but you have evidence of persistence of female genital mutilation in the far north of the country. You can see in the image where I put the big round. Far north of the country, and also the southwest of the country. And you can have some mild cases in the main towns of Cameroon, that is in Douala and Yaoundé, with the small circles, where you have those communities from the diaspora community from those main regions that still perform it while being in town. So recent independent survey show that 20% of women has experienced female genital mutilation in the two affected zones, far north and southwest. And also, they talked about possible recent increase of cases in the far north region. Slide, please. So the challenges to the eradication of female genital mutilation is strong cultural beliefs. You have the silence, because now it is very difficult. It will even have a research. The recent research that I saw, it was very difficult for them. They had to do an anthropologic research inside the community to try to get it, because I thought about law enforcement. So when you talk about law, people start to hide it and so on, to maintain their culture. So it's very difficult to identify girls who face that. We also have the socio-political context in high-risk zone. Like, for example, the far north, we have this conflict with Boko Haram. So most of the external partners and funders left the zone due to security reasons. And also, as I said, like we have less than 5% cases nationwide. So people, if you ask, I had some people, some friends who work in UNFPA who say, but why are you talking about female genital mutilation in Cameroon? You are not concerned about that. But we are. There are still some cases. We have not yet completely eradicated that. And we think that we still have to work on it. Slide, please. So yes, we think that we still have to work on it, and this is the conclusion, because female genital mutilation is a practice which has no medical indication and is considered as a violation to human rights, a deep violation to women and young girls' rights, sexual and reproductive rights. So we had this significant drop in Cameroon, but the efforts have been hindered by several challenges, and we think that we still have to make some research on it. So yes, it's the same feeling like the precedent speaker. People don't do research on that. You have difficulties to have the research papers on that. So we have this gender-based violence study group in our design, which is piloted by Professor Maswime. And one of our sites is Marwa in the Far North region. So we are trying to see if it is possible. It will be challenging because, as I said, people are not talking about it. They don't come to the hospital, but we will see if we can have some literature and if we can assess it and help to completely eradicate it. Thank you for your attention. Next, these are my references also. Yes, so WHO UNFPA, this is the study that I talked about, the recent study in 2002. Thank you very much.
Thank you so much. Let me stop. Thank you so much for your talk. That was amazing. Thank you for informing us and making us aware of such. We just have one hand up. We're about to reach our time. I'm just going to ask just probably 2 questions, one for each speaker. If anyone has any questions for one person for each speaker, please.
I'll go first. And again, thank you so much, Dr. Fanny, for an excellent presentation. And I think this was just eye-opening on many levels. I've got a comment for you and then a question for Dr. Sam. I think, I mean, the fact that the country is able to measure the reduction from 40% to 1.4 to less than 1.4%, I think is quite excellent, because it shows that there is, that there's data being collected and it's being measured. And also the fact that legal enforcement was used to eradicate this practice, also meaning that in South Africa we can learn something from that in terms of the male circumcision. But for Dr. Salgazana, my question, which has always been a global surgery issue, the mass circumcisions which were brought in to reduce the transmission of HIV, and that has become an ethical concern as well, because it's only Africans. It's not being done in other parts of the world. I'd just like to know what is your opinion on whether this was the right way to go to enforce these mass circumcisions. Again, many NGOs have made a lot of money through this. So what are your opinions? Thanks.
Yeah, no, thanks a lot for that question. So I think there is reasonable evidence to suggest that there's a reduction in transmission, but I think the problem I have with that is that often an ordinary community member would think that's a substitution to not using other methods. Because the reduction, I don't have the real numbers, but I don't think it's significant enough for us to be preaching that much as there's definite evidence. Because like I said, most people tend to substitute that then for not using the methods that we know very well, like barrier methods that actually do reduce the risk of HIV. So that's my take on that. I think the evidence is there. But it's not, for me, it's not good enough if you're gonna sell it as that, because everyone else just go for a circumcision and the next thing we're sitting with a bigger problem. So that's how I see it.
Thank you so much. I think Dr. Pule has a question. I see her hand is raised there. Hi, Dr. Pule.
Hello. Yes, I do. Firstly, thank you so much for such an eye-opening presentations, especially Dr. Disak, because, well, I'm a woman. So listening to that, I was quite shocked and saddened to know, like, what are the repercussions or challenges after what women go through because of mutilation. But I also had a question on your slide where you talked about the situation in Cameroon. Well, Professor Loom mentioned that the reduction, that was really good to see. However, I was shocked again to see that they said girls between 5 to 9 years are more likely to be mutilated. How are the children's rights being considered within that side of the country? Because it's so sad to know a girl, like a 5-year-old. This side they're still developing, because I'm asking this because in South Africa we do have the children's rights, which are included in section 28 of the human rights. Hence I'm asking in that context. Yeah.
Yes, thank you for the question. So if I got the question, you're asking, how do they identify those children?
Yes, and also in terms of their rights, is it legal, like for young girls within that age group to go? I do understand some people, they do have their own cultural beliefs, but isn't there any people working towards ensuring the children's rights are being met, like challenging this besides obviously what you've mentioned? Yeah.
Yes, you know, it's as you are saying, it is illegal to do it at any age because, as I said, you know, the difference with male circumcision is that there is a debate, like Prof. Maswime was saying. Some people say, okay, it helps to prevent HIV and so on, but female genital mutilation or female circumcision has no medical advantage, or there's no reason that you can do such a harm to young girls. So, but they are brought to those ladies. It's cultural. When you have that cultural belief, you see a young girl at the age of 5, or maybe they say, okay, they have to do it because it's a ritual. You have to do it in order to be a good young girl. You have to do it. The earlier we do it, the earlier you will be pure for your husband and so on. So it is essentially due to their beliefs. And yes, it is illegal.
Thank you.
And sorry, for the survey to have the data, it is difficult. We usually have the survey with the, as I said, the DHS, the demographic health survey. So here to ask, it is when we assess, you ask you ladies, have you ever faced that, yes or no, and at what age approximately? So this is how we have those indirect data. You cannot have, we don't have, I'm not sure we have data about fresh cases. As I said, the last survey dated 2004, and this is why the other ones are journals and so on who say there is possible resurgence, but we are not sure, and we want to be sure with this research.
Great. Okay, thanks.
Thank you so much. I see there's a couple of hands because it's quite an interesting topic, but unfortunately we've run out of time. I think it would be great if we, is there a way we can contact you guys if we have any burning questions? Can we send emails and then we probably can respond in our next meeting or so, sometime just to clarify. Yeah. Is there a way, can we contact you guys just to find out any more burning questions? All right. Thank you, everyone, for for coming to today's academic talk. Thank you to our two speakers. Thank you so much for shedding a light on such an important global surgery topic. And I hope we really can do something about it and find out more on ways to prevent such traumatic and devastating mutilations of kids' human rights and human rights in general. And I think that's the end of the talk right now. For those who have questions, we'll definitely ask the speakers if they can, we'll send an email to the speakers if they can respond to the email, to the messages. Thank you, everyone. That's the end of the meeting now.
Bye.
Bye-bye.
Thank you.